So, good afternoon all. On behalf of Pediatric Unit 3, I, Dr. Kanaram Jat, welcome you all for the CCR. So, today we will discuss a child who has the multiple complaints and he was diagnosed with an unusual entity that is relatively new. So, case will be presented by Dr. Aswini and Dr. Jagat will discuss the review. So, I request Dr. Aswini to start the CCR.
Good afternoon, everyone. So today's clinical combined rounds by Pediatrics Unit 3 is an unusual cause of a multi-system disease. So our patient, a 13-year-old male child, was admitted on 18th of January 2020. He presented with complaints of fever and abdominal pain for 3 months, vomiting, yellowish discoloration of eyes and urine, cough and fast breathing, and left knee joint pain for the last 1 month. The fever was intermittent, low to intermediate grade, associated with chills. The abdominal pain was also intermittent in the bilateral flank region, increasing with micturition, and also in the right upper quadrant of abdomen. The vomiting was episodic during the episodes of pain in the right upper quadrant of abdomen. Yellowish discoloration was also episodic. It was associated along with the pain abdomen and fever. Cough and fast breathing was also there for the last 1 month. It was associated with scant sputum production. The patient also complained of history of generalized myalgia and easy fatigability for the last 3 months. There was also history of reduced appetite for the last 3 months and history of paleness which gradually increased for the last 3 months and history of pain in the left knee joint for the 1 month associated with swelling and restricted range of movement. In the negative history, there was no history of bleeding from any sides, no history of redness of eyes or skin, no history of swelling anywhere else in the body, no history of photosensitivity or hair fall, or no history of any contact with TB, any night sweats or weight loss. There was no history of palpitation, orthopnea, or discoloration of fingers on cold exposure, no history of any epistaxis or persistent nasal obstruction or severe facial pain, no history of any oral ulcers, or no history of passage of any blood in urine. In the past history, there was no previous hospitalization, no history of asthma, allergy, or contact with TB. Birth, immunization, and developmental history were all normal. In the family history, he was a third-born child out of non-consanguineous marriage with no history of any similar illness in the family and no history of TB contact, or other 3 siblings were alive and healthy. In the previous treatment history prior to admission, the patient had fever and for which he was initially treated on OPD basis outside. The evaluation for fever was done outside and he also developed abdominal pain and urinary symptoms and later jaundice and cough, for which he was admitted outside and he received IV antibiotics and supportive care. He was also started on ATT suspecting disseminated TB on the basis of a positive MAN2 test which was 15 millimeter and gene expert was negative in this patient. He also received blood transfusion thrice outside. The doses of ATT was adequate. He received 2 months of HRSD. However, the symptoms persisted despite the treatment and following which he was referred to AIIMS. And at presentation on examination, the patient had a mild tachycardia and tachypnea. Other vitals were normal. Anthropometry was also normal for age. And on general examination, he had pallor, significant lymphadenopathy, cervical, axillary, and epitrochlear. Epitrochlear was 2 into 1 centimeter. He also had icterus, and there was no edema, clubbing, oral lesions, or skin lesions. On systemic examination, in the respiratory system, he had reduced chest movement and chest expansion on the left side, along with reduced air entry on the left infraaxillary area. Other findings were normal. In the abdomen, he had mild tenderness in the right upper quadrant and liver was palpable 1 centimeter below the right costal margin. And in the cardiovascular system, he had a hyperdynamic precordium and other findings were normal. In the musculoskeletal system, he had a left knee swelling along with mild tenderness and marked restriction of the range of movement. There was no redness or warmth and rest of the joints were normal. So in summary, my patient was a 13-year-old child with complaints of fever, abdominal pain, vomiting, jaundice, knee joint pain and swelling with no response to anti-tubercular therapy, with lymphadenopathy, reduced breath sound in the left axillary region, hyperdynamic precordium and mild tenderness in the right upper quadrant of abdomen along with swelling of left knee joint on examination. So we thought of a few differentials. Those were disseminated tuberculosis, connective tissue disease, lymphoma, brucellosis, and sarcoidosis. And on investigation, on complete blood count, the patient had anemia, severe anemia, hemoglobin was 6.5, and mild leukocytosis 15,940 TLC, and reactive thrombocytosis as well. And in RFT, LFT, all the findings were normal except a slightly elevated ALP 1667, and TSP was 1.2. Bilirubin, total bilirubin was 1.2. ESR and CRP were also elevated. ESR was 72, CRP was 186. Sputum gene expert was sent, which was negative, and procalcitonin and HIV were also negative. We further did a bronchoscopy, and BAL was also investigated. The BAL culture sensitivity, fungal workup, and TB workup were all negative. In the BAL cytopath showed necroinflammatory and acute inflammatory exudates, and stain for AFP was negative. And on further workups, ACE levels and urine calcium creatinine ratios were negative. ANA DCT was also negative. LDH was 173, and Brucella antibody was also negative. So this was a bronchoscopy that we did. On bronchoscopy, we noticed a narrowed left main bronchus with compressed left lower and apical lobe. So in the first and the third picture, we can see a narrowed bronchi. On further course and admission, after admission, the patient had persistent fever, and he was started on IV antibiotics, and ATT was also continued. However, the fever persisted, occasionally associated with chills. And he also had abdominal pain and intermittent jaundice episodes. The pain abdomen was present, which the pain abdomen was in the loin and the right upper quadrant region, and it was associated with increase in the jaundice, chills, as well as elevation of alkaline phosphatase. So here we thought of a cholangitis with cholestatic jaundice as a possibility, and it was confirmed by ultrasound. And later, during admission, the patient developed increase in respiratory difficulty, and the clinical features were suggestive of pericarditis, and it was also confirmed with echocardiography. So the imagings of the patient will be discussed by the radiology team. Over to Dr. Manisha.
Thanks, Ashwini. Good afternoon all. So in imaging, we have these serial radiographs. First one is of January and the second one is of March. Here we can see that in both the radiographs, there is this perihilar haziness that is persistent. So there is a kind of reticular opacities in both the radiographs. In addition, in March, we can see there is one additional finding of a consolidation in the left upper zone. And in CT chest, what we see is that there are multiple nodules, fissural thickening. We can see the nodules in the left upper lobe. There is fissural thickening, and the thickening is also nodular. Of note is that the left main bronchus, as we see in bronchoscopy, the left main bronchus was narrowed, as if something is surrounding the left main bronchus all over. So there was a narrowing of the airway lumen along with peribronchovascular thickening and multiple nodules. In the mediastinal window, you can see the same soft tissue which was surrounding the left main bronchus. It is very sheet-like diffuse flat type, unlike that of nodes. There was no calcification inside, and of course we can see the non-calcified nodules here as well. So overall, this lung picture consisted of multiple nodules as well as kind of fibrosing mediastinitis picture. If we did MR also at the same time, here we could see that on T2 weighted images, this mediastinal soft tissue was very hyper intense, which is unlikely that of a mature fibrosis. But active phase of fibrosing mediastinitis can look like this, but they are not looking like big enlarged lymph node or necrotic lymph nodes. And this was the MRI abdomen. So MR abdomen has some striking findings. One is that in the first image we can see that there is the pancreas. The pancreas is appearing it is showing loss of lobulations. So normally the contour is feathery or lobulated. Now here it is becoming very smooth or sausage-like appearance. And there is a very faint T2 hyperintense ring at the periphery. So these findings can corroborate with an autoimmune kind of pancreatitis without much enlargement of the pancreas. And the second image is of MRCP, which shows that there is sclerosing cholangitis type of picture. Normal biliary radicals should taper distally. Here there is irregular taper, narrowing and beading appearance. So overall, these pictures can fit into autoimmune pathology. Yeah. And LCH rarely can give this kind of picture as well. But LCH leading to fibrosing mediastinitis is again rare. So this was the MR abdomen diffusion weighted some additional images. The of striking finding is that first one is the diffusion weighted image, second is the ADC map. This pancreas is showing up brightly on the diffusion weighted, and on ADC map it is appearing hypointense. So this is the pancreas which is showing a diffusion restriction. This is again a finding in cases of autoimmune pancreatitis as well as a spectrum of connective tissue disorders or autoimmune disorder. Thank you.
Thank you, Dr. Manisha. So at this point, we were in a diagnostic dilemma as none of the findings were fitting into any of the common diseases. So we thought of a possibility of IgG4 related disease in this case. The points in favor were fever, joint pain, lymphadenopathy, mediastinal fibrosis, pulmonary nodules, retroperitoneal fibrosis, cholangitis, and pancreatitis. So we sent the IgG4 level for this patient. It came out to be 13 grams per liter. The normal levels are up to 1.4 gram per liter. So further, we did a biopsy of the epitrochlear lymph node, and the histopathology of the same will be discussed by the histopathology. Thank
you. Good afternoon, everyone. I'm Dr. Sulaiman, Senior Resident from Pathology Department. So we have received an excisional biopsy from the epitrochlear lymph node. So this is a low power view of a lymph node where we can see a maintained architecture with the presence of lymphoid follicle, and this is a germinal center surrounded by mantle zone. And between the cortex lymphoid follicle, this is a paracortical area. In the low power view, we can see only the vascular proliferation. This is a high power view of the paracortical region, which shows along with vascular proliferation numerous lymphoplasmacytic infiltrate, and which can be identified by presence of eccentric nuclei and cartwheel appearance. So with this morphology, actually we can think of quite a possibility, as radiologist said, its autoimmune condition will be possibility. But they made a job easy for us since they have done an IgG4 level and it's quite elevated. We have performed a stain for IgG, which showed positivity for IgG in the plasma cells. So in order to say that IgG4 related disorder, we have to do IgG4, which should be approximately more than 40% of IgG4 in total population of IgG. So the final possibility we have suggested is IgG4 related lymphadenopathy. So these are the histological subtypes of IgG4 related disorder. So which is multicentric Asselman disease, reactive follicular hyperplasia, interfollicular expansion, progressively transformed germinal center, and inflammatory pseudotumor. In interfollicular expansion and immunoblastosis, these conditions can be also coexistent with the rheumatoid arthritis and many autoimmune conditions like SLE are increased in the IL-6 level. So based on the morphology and with the clinical and serological features, the best possibility would fit in the diagnosis of reactive follicular hyperplasia like IgG4 lymphadenopathy.
Thank you, sir. So we finally made a diagnosis of IgG4 related disease in this patient. And as a treatment, we started the patient on prednisolone tablet 10 mg TDS for the 2 weeks, and then gradually tapered the dose. And he was also started on tab ursodeoxycholic acid for the cholangitis, and tab lacilactone was also continued for the pericarditis. And following the treatment, child became afebrile after 5 days of steroids, and he became symptomatically better. The pain abdomen also reduced and appetite improved. He was tolerating feeds, and there was also radiologic improvement, and he was discharged on oral medication. And on further follow-up, he was readmitted after 24 days of the discharge with fever, hemoptysis, pain abdomen, and vomiting. And on investigation, there was TLC was 32,000, which was neutrophilic. ALP was 521. He also had some oral lesions, and scrapings for HSV were, however, negative. A diagnosis of pneumonia was made in this case, and he was discharged after becoming afebrile, and he responded to antibiotics. On last consultation, he was on tapering dose of prednisolone and also on Udiliv and lacilactone. They were continued, and he was symptomatically better. alkaline phosphatase was on reducing trend. IgG4 was planned for the patient, but it could not be done due to the current scenario. And repeat imaging was also planned after a course of prednisolone. And currently he is on prednisolone 5 mg alternate day. So the further discussion will be done by Dr. Jagat.
So good afternoon, everyone. Today, this case going into the very brief discussion of the disease. It's a multi-system disorder, and it's basically immune-mediated fibroinflammatory condition. And it has been unrecognized as a unified disease for well over a century, and people have described in medical literature as this is likened to a black crow flying through the dark night. As people were aware there is something wrong, that a disease can explain so much of abnormality, but they're not able to figure it out. So basically what happens is there will be a tumor-like infiltration of IgG4 positive plasma cells in the tissues. It did not appear in the medical publications till 2003, and the first case series from Japan, they have mentioned of this disease from the publication in 2003. And then initial prevalence of the disease can be linked to the study on autoimmune pancreatitis from the different studies from Japan. And the real study and the real light into the incidence came from a series from Japan, where they have shown the incidence of the disease is estimated to be around 0.28 to 1.08 per lakh people. And the nationwide registry of the disease from Japan, they have shown 336 to 1300 patients to be newly diagnosed to have IgG4 related disease. And it's a disease of middle-aged people, and unlike other autoimmune condition, it's more common in the male. And the exact prevalence, especially in children, is largely not known, but it is a very uncommon disease. The data on epidemiology in children is not that great. We don't have much data. There are a few case reports only, and based on this case reports, we can see the disease has been reported from as young as 3 years to 17 years, and male female are mostly equally affected, and the manifestation is highly variable. The pathobiology physiology centers around the activation of the helper 2 cells and leading to increased proliferation of the beta cells, leading to increased production of IgG4. But what is the trigger that leads to increased proliferation of these cells is not that known, but there are certain triggers that are hypothesized, like autoimmunity that is triggered by certain HLA, molecular mimicry with some organisms like Helicobacter pylori. They all lead to increased activation of TS2, leading to proliferation of the beta cells. Next, hallmark of the disease regarding the immunopathology is the activation of the regulatory cells, because these have been shown to be increasingly associated with the activation of the FOXP3, which is a marker of the T regulatory cell, and it has been associated with the severity of the IgG4 disease. All these lead to increased proliferation of B cells, and that lead to increased proliferation of the IgG4, which in normal condition of health is very low, and that gets deposited in excess amount in different tissues, leading to tumor factive enlargement and organ dysfunction, leading to the different manifestations that we witnessed in our case. The spectrum of manifestation, as we discussed, is highly variable. These are some of the important manifestations. These have come well in different literature in the adult population, like dacroadenitis, sialadenitis, autoimmune pancreatitis, sclerosing cholangitis, retroperitoneal fibrosis. And there have been observations they may be having one or more of these manifestations in overlap. And so different, the manifestation is typically a myriad with a combination of one or more of the explained. Going to the clinical manifestation in children, we do not know much about how this disease typically manifests in children. And this is one systematic review that has been published, which includes 25 cases from 22 case reports. And the cases included from 22 months to 17 years, and the median age was 13 years, and most of the patients were girls. And we can see most of the cases were having some IgG4 related retroocular disease, then autoimmune pancreatitis, cholangitis, pulmonary disease, and remaining they had a combination of a retroperitoneal fibrosis, Hashimoto's, Riedl's, thyroiditis, and so on. So diagnosis is based on a combination of imaging with which is supported by compatible clinical findings, then histopathology, and there is role of serology in terms of the IgG4 level. So the diagnostic criteria initially was proposed in 2012, and this has been improvised in 2015. And basically there are three criteria: clinical, radiological, histopathological, and serological criteria. Then the histopathologic criteria already explained by pathology team basically demonstrates the increased level of the IgG4 in the form of more than 10 IgG4 cell per HPF or more than 40%. Then serology of IgG4 more than 1.34. As a definite when all three case criteria are met, probable when this clinical and the histopathological are met, and possible when clinical and serological criteria are met. So on a very brief about the IgG4 level, when you have this clinical suspicion, we tend to send IgG4 level, but it is neither sufficiently sensitive nor specific for diagnosis, because many of the cases of IgG4 disease, they tend to have normal IgG4 level. And even if different non-IgG4 conditions like autoimmune disease, allergic conditions, carcinoma, and Castleman's disease may have elevated IgG4 in level. And treatment, steroids are the cornerstone of the management. Basically, there are two kinds of regimen that are well described in literature. One is the high dose of steroid given for a short period and briefly tapered, and next is the lower dose given gradually tapering. And there are no RCT comparing these two regimens, but people are following different regimens and different settings. If we look into the Japanese series, because they have the most of the data and the case that are described in medical literature, they usually start with a very low dose, and they try to keep the patient on a maintenance corticosteroid. And what they have observed is that if they keep on this maintenance low dose corticosteroid, this patient tend to do well, and the relapse rate seems low. Follow-up clinical improvement along with the serological assessment and radiological assessment are important, and the response to steroid depends on the type of the organ involved and whether there is a predominant fibrotic condition. The endocrine and exocrine pancreatic function, they have good response, and these fibrotic conditions, they are less responsive to corticosteroids. So again, IgG4 has been used in monitoring these cases, but it has been observed in many cases IgG4 has not normalized even if they were doing well with corticosteroids. There are some alternative therapy in patients who have relapsed despite prednisolone maintenance therapy. The MMF, azathioprine, methotrexate, and immunoglobulins have been described in literature, and they have been used when corticosteroid dose could not be tapered due to persistently active disease. And there are some descriptions of using rituximab in these cases, and this is a case series of 4 patients who have been who did well with rituximab. Following rituximab, this patient could be tapered of the corticosteroids. To summarize, IgG4 related disease is a progressive multisystem disorder. Early diagnosis is very important to prevent the complication. Corticosteroids is the mainstay of treatment. And it's very important that we do not have much data, and much data is evolving, which would improve the understanding of the disease. And especially in children, the prognosis of the clinical condition we are not that clear, but we need more study. But one thing is clear, that if you diagnose early and if we treat, the morbidity and mortality can be reduced. So thank you.
Thank you, Dr. Ashwini and Dr. Jagat. So this child we have the confirmed diagnosis based on this imaging and histopathology and the serology. So we have 1 or 2 child also the similar disease, IgG4 disease. One was having the retroperitoneal fibrosis. So this retroperitoneal fibrosis, mediastinal fibrosis, these are the we have seen the common in the pediatric age group with the disease, and they respond well to the steroids. All these emerging disease in last one decade only there cases are there. And now it's open for the question comments. So there one question from the in this YouTube. They asking about this clearing of the left upper zone opacity. So after treatment, the opacity was cleared, although we don't have the unfortunately X-ray of this follow-up X-ray. And we didn't repeat that this bronchoscopy to see the narrowing. It was improving, not improving, but the opacity was improved in the follow-up. Yes, ma'am.
What is the normal age of presentation, earliest age of presentation? That was not covered.
Yeah, usually is reported in adults. We discussed now the 40 to 50 years age. Only around 20 cases reported in the pediatric age groups. I think youngest, the 6-7 years was there in the youngest age group that was reported.
What is the cause of UTI? Was there any concomitant anomaly?
Sir, usually there is a ureteroperitoneal fibrosis that causes the structure of this ureter. That is maybe respect for the UTI.
So, was there an obstruction or something?
Yeah, obstruction is a. No, it is really rare to have this both disease together. So on the outside there was a mandux was positive, and based on the imaging that it appears like the median lymph nodes, and there was a shadows in the lungs also. So it was studied on the ATT, but we stopped the ATT after we established the diagnosis. So because we didn't find any microbiological diagnosis, gene expert outside also negative. We also confirmed that in the wall also in the it was negative. So we didn't consider tuberculosis here.
Because the rapid simulation is also been factored that
Yes, ma'am, this is highly variable presentation. So this is IgG for disease.
Dr. Rana, one question. Last year, I think recently another case was presented of autoimmune pancreatitis by I think previous revision, presenting as a mass, pancreatic mass. Women release, could they present as mass personally? And if they are presenting as mass, apart from systemic symptoms, are there any real measuring findings which can help us to check on pancreatic tumor?
Usually presentation is autoimmune pancreatitis. I'm not sure about that. This is represented the pancreatic mass or imaging findings.
So,
But yes.
I'd like to. You were talking about the same patient, Pete Gastro, presented with Dr. Rohan Malik last year. So actually, that was very unusual presentation of autoimmune pancreatitis presenting as a focal mass lesion. That is very, very unusual. But that is known, a rare presentation of autoimmune pancreatitis, and it very well mimics a mass if it's seen in adults. In children, we know that pancreatic adenocarcinoma is as such very rare. And there are a few findings which has been described as differentiating soft points, like the duct will be going through the lesion well, unlike that in adenocarcinoma. But there again, in a given case, it is very difficult. Enhancement characteristics have also been known to differentiate between the two. But in a given case, it is always biopsy.
When do you suspect the underlying etiology could be immunogenetic? Is there a panel of tests you do? You come to a level after some investigation, they were not fitting into this, and then you go for. Is there a panel that you do? How do you get to know?
In this class, so we firstly through the common conditions like TB, hypothesis, brucellosis. But once we rule out the conditions, then imaging was suggested the IgG4 disease. Then we work up for the IgG4 disease. At the first, we didn't suspect this condition. If the no more comment, then final comment from the Kavarasa.
The reason for presenting this case was that it is mimicking that of a common illness, like as you said, it may be tuberculosis. So there is a pulmonary involvement, there is an organomegaly, there is lymphadenopathy. In our country, you will think of tuberculosis. But if a patient is not responding to anti-TB drugs, you do not have objective evidence to say that it is tuberculosis. You have to think of other alternative cause. And that is the reason that we should not be that if it is not responding, it is TB, we do not have alternative cause. We do not have objective evidence that you think of drug-resistant tuberculosis. That is the usual story. Second thing is, generally, this is not so rare in adult patients. And they are having access to a tissue, like a retroperitoneal fibrosis, and then they take a tissue do a specific plasma cells and IgG for staining, and then the diagnosis is clear. Here, because children, we are doctors, small children, we don't have that big heart to get the blood tissue out. So we discuss it with our pathologists, that whether they can help us. So this is not a routine to do a special staining for IgG4 on lymph node. So they agreed and they did it, and that's how we reached to a diagnosis. So it was with the help of pathology department that we could reach to a diagnosis, and it involved the discussion with the consultants and residents, and that's how we could reach to a diagnosis. This is a rare condition, but it gives this thing that if a common condition is not responding as expected, think of rare disease or IgG diagnosis.
Did it ever come to your mind that the jaundice could be a side effect of the ADT?
Yeah, it was initially it was considered that it is a drug-induced hepatitis, and that's why some modified ATTP drugs were given.
Okay, now we can further discuss. Thank you.
Thank you very much.